Yeah, it is my pleasure to introduce Esther Puyol, who will be our next speaker. Esther completed her PhD in the Biomedical Engineering Department at King's College London in 2018. She then did a postdoc also at King's College London, where she developed deep learning models for automated analysis of cardiac imaging. And in particular, she investigated the biases that can arise from using imbalanced medical image databases for training segmentation models. So this is where we come to the segmentation part. Yes, Esther, please, the floor is yours. We're looking forward to your talk.
Cool. Can you see my screen?
Yes.
Yes, fantastic. So thank you for the introduction and for inviting me here today. Yes, mentioned over the last year, I've been trying to develop AI tools for automatic analysis of CMR images, and a big part of that was segmentation. So after seeing all these papers that showing the potential of bias in medical imaging applications, and also by talking with clinicians where they show that, well, they say that there are some structural as well functional changes in the heart between different races as well as genders. We thought it would be very important to analyze if this bias could also be seen in a segmentation task. So for that, what we proposed was to use a state-of-the-art segmentation network, in our case, the NNUnit framework. And the input data is going to be an MR image, which you can, for those that it's not familiarized, it's kind of a 4D image where you can see the full heart and as well also the motion, because it will be imaged throughout the full cardiac cycle. And based on that, we want to mimic a little bit what clinicians do and then compute these biomarkers, where are the systolic volume, ejection fraction, and mass. And for that, the idea is to automatically delineate the main chambers of the heart, in this case, the ventricles as well as the myocardium. So for this task, we use the UK Biobank database, which has a particularity, it's well standardized. So the idea of this database is that all the subjects has been scanned with the same scanner and also the same protocol. So in this case, we take out all the extra bias that will come from different protocols. And we also focus only on the healthy a subset of the healthy population. In our case, has around 5,900 cases, for which we have manual analysis made by clinicians. So the idea is, we wanted to train this network in the standard way where we divide the data between training, validation, and test. And here I want to highlight some of the distribution of the population. So you can see that it's kind of a gender bias, gender balance. We have more or less the same proportion for male and female, but actually in terms of ethnicity, you can see that there's 80% of the population which belongs to the white group and the other 20% to the other racial groups. And this is also in line with the current UK population. So to assess this, to perform this analysis, first of all, we just compute the, we assess the performance overall, given the full test population. And for that, we look at two metrics. First of all, the dissimilarity, which just measures the overlap between the manual and the automatic segmentation, where 100% means a perfect overlap and 0% no overlap. And we also then look at the absolute difference on the biomarkers that are used clinically. So here there's nothing really new. So in terms of performance, we are doing very similar to any of the previous methods that has been proposed. But then the next question was, are we also doing as well in the different groups? So for instance, if we look at gender, we can see that we have more or less the same results or the same dice for male and female. And there's only some difference in terms of masses, which could be explained by the difference in terms of sizes between male and female. However, when we look at the race population, we can see here that actually there's quite a difference between the white group and any of the other minority groups. So you can see that goes from achieving a 94% accurate dice to up to 86, 87%. So there's quite a significant drop. And this drop, it can also be seen in terms of absolute difference of the biomarkers. So then the question was, okay, we see some bias, how we can explain this? So the next part, what we're trying to analyze if any covariate could explain this difference in terms of dices. So for that, we look at the most common covariates being age, gender, some height, weight, blood pressure, and also some biomarkers, as well as the presence or absence of risk factors. All of these are being shown in the literature that could have an effect on there are some difference between the racial groups. And also we incorporate center because the annotations were made by different experts, and each of them in theory follow the same protocol, but it might be also that there are some difference between the annotators that could be explaining this bias. So for the standardized multivariate regression, we showed that actually none of these coverage could explain 100% this difference on dices. However, center has a weak association with dice, and for the mixed and the Black population, also gender has an association with dice. So what it means here is actually there are some changes in the annotation protocol, which may affect in this bias, but cannot be fully explained by that. And also that gender could be one of the small differences that can lead into difference on dices. And in the ANCOVA analysis, what we showed that the overall factor that explained the difference of dices was race. So again, there couldn't be a clear biomarker or something that could explain all this bias. So then the next question was, if we see that there's a bias, it cannot really be explained. Will it have an effect on the diagnosis? So for that, we took an oversimplification of problem. So this not be 100% accurate, but it's just for trying to highlight what is the potential or what will be the effect of the bias. So in this case, we wanted to get the task of diagnosing heart failure. So in general, what they do clinicians is they look at the ejection fraction. And based on that, if they also know that they have cardiomyopathy, they will be classed in 3 different groups. Heart failure with reduced ejection fraction, heart failure with moderate ejection fraction, and heart failure with preserved ejection fraction. And depending which group you've been classed, you have a certain treatment that you're going to be giving. So in comparison to the previous network, we trained this network both using healthy as well as pathological cases, and we tested also in healthy and in pathological. And for the cardiomyopathy patients, then we compute the misclassification rate between the manual and the automatic ejection fraction. So you can see here that for the white group, the misclassification rate is very low for the 3 categories, less than 8%. But for the minority groups, actually, we have quite a big misclassification rate, up to 45%, which will have a very big impact on the clinical diagnosis, of course. However, here, as you can see, we are using quite a small numbers. So we have a maximum 14 cases for a given group. So in order to make more statistical sounding, we then compile all the minority groups and to make the analysis all together. And we see that in this case, in overall, we have a misclassification rate of 23%, which is quite significant and it's quite big if we want to then use this method in clinics. So then the next part was, okay, now we see there's this bias, how we can try to mitigate it. And looking back at some of in the first talk where Andy showed the different algorithms that has been proposed in the clinic and the computer vision literature, we proposed 3 different approaches. The first one is what we call stratified batch sampling. So here the idea is just to try to feed the data into the network in a more clever way. So currently most people, they just randomly select a subset of data for each batch and just feed it into the network. So here, instead of doing that, we want to have we want to give more importance to the minority groups. So we are going to be oversampling these minority groups per batch. Then the second approach is what we call metaphor learning. In this case, we are doing a multitask approach where we train the segmentation as well as a classification network based on the output. The classification is going to try to guess which is the racial group. And by training these 2 together, we are hoping we are enforcing one to another and then making the network or the segmentation network a little more fair. And the third approach is kind of the naive approach where we say, okay, we have different races. What if we try different segmentation networks for each of the different races and see how well we are performing? And finally, as a comparative approach, we work with a balanced data set. So we just took a subset of each of the data in order to have the same number of cases for the different races. And here you can see the main results. So in terms of how good the network is performing, again, as before, we are using dice coefficient. And then in terms of fairness, we are using standard deviation and skew error rate. In both cases, we want it to be as low as possible. So if we look at the baseline, it's the same as we were showing before. We have quite good numbers overall, but we see that the white population is doing way better compared to any of the minority groups. And then for the proposed bias mitigation strategies, the one of the protected groups, so the one that we train a different network for each of the racial groups, is the one that show better performance, both in terms of standard deviation as well as skewed error rate. But also interestingly, overall, you see the average, it's better than compared to the baseline approach. However, one of the limitation of this approach is actually we need to know what is the race at inference time. And this is not always possible in clinics or even when using some of the public available databases. And also there may be some subjects that may be in between groups, so they won't be very clear to one of these network apply. So then a second approach is what we call the stratified batch sampling. So the one that we are just sampling the data in a more clever way. And you can see here that, again, it's also reducing significantly in terms of bias, but also the average dice coefficient is higher compared to the baseline. Also, I want to highlight something. If you look at the baseline at the white group, this is the one achieving the highest number, around 93%. And you can see that somehow by having information from the other groups, it's also helping the white group, because in the other approaches, this white dice, it's decreasing. And finally, when looking at the comparative approach, you can see that this one is the one that achieves the best in terms of fairness. However, there's a clear decrease in terms of dice. So it goes from 87% to 80%. So it is again the question of what is the trade-off between a more fair algorithm and the accuracy of the network. So in conclusion, here we show that for the first time that exists racial bias in deep learning-based cardiac MR segmentation models, but not gender bias. And we think this is because of the use of an unbalanced database, and also the difference that there are no confounder that could really explain this difference in bias, but that some of the proposed bias mitigation strategies could help in order to reduce this bias. But then as a next step, one of PhD of Andy Ahmadi, Anna Lee, she has performed a systematic analysis trying to see what is the influence of using unbalanced databases for training. And this work was presented this year in ICAISTCOM 2022. So as mentioned before, the idea was to see how the training with imbalanced databases will affect the performance. So for that, we performed 3 different experiments. In the first one, we wanted to assess the effect on gender, and the other 2 effect on race, especially looking at Black versus white and Asian versus white. And the idea here is there will be training with 5 different databases. The first one where we have 100% of the first group and 0% of the second group, and then changing the percentage 75, 25, 50, 50, where we have a balanced database, up to the point where we have 100% of the other group. Similar to before, we are using the UK Biobank data only with healthy volunteers, and where we also have the annotations. And if we look at the baseline or the patient characteristics, we can already see that there actually is some difference, for instance, in terms of height and weight for male and female, which is not surprising, as in general, male are a little bit higher and bigger compared to women. But if we look, for instance, at race, we also see some difference, such as the Black population is slightly younger compared to the white population, and the Asian population has a slightly lower BMI compared to the white population. So this is, again, there are already some differences that may be also helping in order to make this bias even more profound. So similar to before, we are using the NNUNet network as a baseline segmentation network. And here you can see the main results. So in the experiment 1, just a reminder, is the one we want to assess the performance in the gender group. So in this case, you can see that regardless of the percentage of male, female on training set, actually we see that there's no statistical significance of any of them. However, in the case of the racial groups, we can see there's a statistical significance for most of the experiments. And it's very interesting that in this case, the one that achieved the optimal accuracy, or the most fair accuracy or similarity between the both groups is when we train with 75% with white and 25% of Black or Asian. And our hypothesis here, it might be that it's actually because the white population is more diverse, and actually it's also helping for the other racial group. So in conclusion, similar to before, but this is taken one step further, we perform this systematic analysis, and this is the effect of using an unbalanced database on training. And also in the future, what we like to do is try to also see if now with using these different percentages, we can find that any confounder can explain this difference, or also look at other demographic bias such as age and socioeconomic status. And in the last part of this talk, I just want to also show another application for segmentation, but in this case, it's brain MR segmentation, and this work was proposed by Stefanos Ioannis in MICAI 2022. So similar to before, the task is brain segmentation, and the idea is that in this case, we could maybe train only with white subjects and then change the percentage of male and female. And the evaluation is going to be both in terms of gender as well as race. So for the results in terms of gender, in the bottom, you can see that overall there seems to exhibit some difference between different male and female. And then on the top bottom, on the top figures, you can see the same results, but this is stratified for the different regions of the brain. And you can see that in average, these regions decrease as the proportion of female subjects in the training set decreases. And this is especially true for certain regions where the bias seems to be more profound compared to the other regions. And similarly, for the racial experiments, we see here that we see also some bias difference when trained with different percentage, and this is especially true for using the Black female test set. So you can see on the left-hand side, again, stratified for the different regions, that this drop in performance when we train with white trained models and evaluating the Black females is the biggest one. And it seems that actually there's more bias in comparison to the sex experiments. So in conclusion, similar to before, we can see that actually there's also exists bias in segmentation-based tasks. And compared to the cardiac, it seems that there's also somehow it's related to the region of the brain. And of course, in the future, the idea will try to see if this could be explained by any clinical factor. So with that, I want to thank everyone who has contributed to this work, and of course, for everyone to listen. I will be very happy to take any questions.
Thank you so much, Esther. This was great. Maybe I will open up the discussion with a question that is also inspired by two people from the chat. So in this first part of your talk, you had this result where you compared a number of different bias mitigation techniques to training on the different groups and to training on a balanced data set. And the results were that the best was to train on a balanced data set, which was interesting as a result. And the other one was that the protected group training was also very good. Yes, I'll give you a second to. Yeah. Yes, this one. Yeah, excellent. And so my question is, so for having different models for the different protected groups, you need to know which group a patient belongs to. And this ties in with a number of questions we had in the chat regarding like these demographic categories are somewhat arbitrary, right? I mean, you had groups like other, and like for gender and sex, you also have all of these discussions which categories you want to look at. So there's a whole discussion to be had there, like what categories to choose, and also whether you can assume knowledge about this, about a patient. Do you have any, I know it's a mean and broad question, but do you have any thoughts on this?
No, I completely agree. In this case, we just wanted to see with the most naive approach, just say in the ideal scenario where we have access to them, how good we are going to be doing. But I agree, this is not really a really good way to go, because there are many differences in terms of, especially how people have self-defined in terms of race. In this case, the UK Biobank is self-reported, so you cannot really guarantee that what has been written is actually the case. And as I was mentioning before, there are some cases that will be kind of in between two races, one from a place, that from another one. So this won't be really the way to go. But it's still quite interesting that somehow it's again linked to the idea of the papers that were shown at the beginning, where it seems to be some distribution shift between patients or subjects from different races. So maybe this is why it's encoded here. And even if not being perfect, the classification, it kind of helps into the training.
Yeah, I mean, it is interesting how well it performs in terms of fairness. It does look very attractive in that regard.
Yeah.
And there was another question regarding the cause for the bias shifts that you found, and I would personally also be very interested in that. So do you have any explanation for why you see these biases occurring? I think that question referred to the third part of your talk.
So the brain one?
Yes, I think so.
Okay, so this is not my work itself, but so I cannot really say, but I think this is going to be kind of future work where they will try to look why could be explaining this difference, especially why it seems that some certain regions of the brain seems to have more bias than others. I don't know if it's something, again, related to the sizes, especially for gender, that female having maybe smaller regions compared to men, but I won't be able to say more about that, I apologize. But hopefully future work will be.
I can very much relate. We recently had a similar paper, and it's not always obvious, right? I mean, you do observe these biases, but it's not immediately clear where they come from, and like not even clear where to start looking for the source. It can be many different things, and it's not trivial to identify a clear source?
For instance, on the cardiac, we did look at the image itself and try to see why some of them fail and some of them don't fail. And there wasn't really anything clear. It wasn't like one of them having better image quality or sharper edges or anything. So clear there was something behind anatomically or something makes difference, but it's hard to say. Yeah.
Yeah.
I don't know if I can quickly jump in there, but so I was involved in that work as well. And the neuroscientist that we work with, he says there are clear differences in brain anatomy especially between races, but also genders, to the extent where you can even tell what race, or certainly for Asians, you can tell that somebody is an Asian just by looking at their brain scan. So I think it's much more clear in the brain that there is such sort of distributional shift than there is in the heart, because I don't think any cardiologist would claim that they can tell the race of somebody by looking at their heart.
Thanks, Andy.
Thanks. Yeah. Okay. If there are no further questions, I think I had all the ones in the chat. Then maybe we will just thank you again for this great talk and move on to the next speaker, who will be introduced by Veronika.